we need to have functioning information as the third indicator in health statistics, as much as we have data on mortality, morbidity. And I would like to see the growth of a scientific community that actually takes this seriously and advances the field.
Hello and welcome to this Frontiers Forum deep dive session. I'm Lee Baker, the Editorial Adviser at Frontiers in Science, Frontiers' flagship multidisciplinary open access journal. Today's deep dive focuses on this article hub on the human functioning revolution. The centerpiece of this hub is an article that explains how and why the World Health Organization concept of human functioning should be implemented systematically in health systems and health sciences to benefit individuals and societies, and also to help achieve the UN Sustainable Developmental Goals on health. It even advocates for an integrative new field of human functioning sciences. It's a centerpiece of a hub that also includes an editorial by Francesco Colombo, head of health at the OECD, together with viewpoint articles by the peer reviewers of the lead article, and a policy outlook as well. You're going to meet many of these contributors today. There's also a lay explainer and infographics and a video and various infographics as well. The aim is that this can be accessible to all audiences. In today's deep dive session, you're going to hear from many of the contributors, and this is the agenda for today. First of all, Professor Gerold Stucki will introduce the human functioning revolution. Professor Sara Rubinelli, also from Lucerne, Gerold Stucki from Lucerne and Sara Rubinelli, also from Lucerne, will essentially introduce the concept of human functioning and its role. Professor Jerome Bickenbach will, sorry, I beg your pardon, the next presentation will be Dr. Frederico Guanais from OECD, and then there will be a moderated discussion where Professor Gerold Stucki and Professor Jerome Bickenbach will moderate a session together with the peer reviewers of the lead article. That's Professor Walter Frontera from the University of Puerto Rico, Professor Hannah Cooper from the London School of Hygiene and Tropical Medicine, and Professor Birgit Prödinger also joining us from the University of Augsburg in Germany, and lastly, Alexandra Pozorak, who was formerly at the World Bank. So, to our first speaker. Our first speaker is Gerold Stucki. He co-led the Frontiers in Science lead article on human functioning. He's at the University of Lucerne in Switzerland. He's professor in the Faculty of Health Sciences and Medicine and co-director of the Center for Rehabilitation in Global Health Systems, a WHO collaborating center. He's also the director of Swiss Paraplegic Research and the ICF Research Branch. That's an international research network under the auspices of WHO. Gerold has been instrumental in advancing human functioning science, particularly in rehabilitation, medicine and beyond, and he's the field chief editor of Frontiers in Rehabilitation Science. Gerold, welcome. Thanks for being here today. Welcome. The floor is yours.
So we need to put the functioning revolution into context, into perspective. And one of the ways to do that is to look at what were the drivers of health over the last centuries. And I guess that in public health, we all agree that the main driver for health in the 19th century was actually the healthy environment. That means clean water, sewage, and nutrition. It was not exactly the medical aspect, it was the environmental aspect. In the 20th century, we have seen the emergence of the curative medicine, emergency medicine, trauma care, cancer, autoimmune systems, and so on. And all this has led to a doubling of the life expectancy. That is the first consequence. But there is also another consequence. The second one is that more and more people, and actually a substantial part of our population now lives with a limitation in functioning. And that is due to chronic conditions that previously were lethal, like cancer, or the survivors of trauma and so on, but most importantly also aging. So this has major implications on how we shape the societal response to persons' need. And the paper has argued that we need to be aware of this, we need to raise awareness, and we need to put functioning at the center of reorienting the healthcare system of the future. That is basically the main argument of our paper.
Thank you very much, Gerold, for getting us underway. Our next speaker is Professor Sara Rubinelli. Sara is another co-author of the Frontiers in Science lead article. She's Professor of Health Sciences with a focus on health communication and Vice Dean of Health Sciences at the Faculty of Health Science and Medicine, University of Lucerne in Switzerland. She's the group leader in person-centered health communication at Swiss Paraplegic Research and a scientific consultant for the WHO. She's also former president of the International Association for Communication in Healthcare. Sara, welcome. The floor is yours.
Thank you very much for all, and thank you to all from the world to be here for this moment where we share our understanding of functioning. And because I come from the field of communication, I always think that is essential that we get the terms correctly among us, because as I will tell you in a minute, the implementation of functioning and to really exploit this concept requires a lot of agreement among us about what we mean by functioning. So let me say that understanding human functioning is relatively easy because it goes intuitively into the core of what matters to us when we do things. On the other hand, it's been extremely difficult when we think about health, well-being. I mean, these are all concepts which have been very much in the tradition, in the philosophical tradition, in the social science tradition for ages. And I would say that functioning goes to the core of integrating the biological health, but also the lived health. So our functioning is what we can do in life. In this sense, functioning is that the main importance is that it bridges between the health and the well-being and societal welfare, because by doing things, so by implementing our functioning, we can reach our dreams, our objectives, and health condition can impact on our functioning in interaction with the environment. And this is why this concept is so important when we think about health systems and how can society respond to the need, the real person-centered need of people. Is basically, functioning is not a new concept. It goes back to the International Classification of Function, Disability and Health. Many people have heard, many people have worked on this concept. However, what we are saying in this article, that it's time to really exploit the concept of functioning as a way to give a new perspective on what matters about health. And in this sense, as we will discuss in this panel today, functioning is perceived as should be perceived as the third health indicator alongside mortality and morbidity, because it is really a point of investment for society and is a way to help us rethink what really matters and where to invest to make sure that people can optimize despite health condition. They can optimize their functioning toward well-being. Implication for health system means that health system should be prepared. It doesn't occur naturally, but we need to prepare health system in their different components to integrate their focus on functioning. And this means that we need to enhance health and healthcare delivery to a focus on functioning, but also recognizes that functioning is an essential concept in health sciences, and here in Lucerne we are exploiting this very much, but in education. And that's why we say in our paper the functioning revolution, because to some extent it is a revolution because it means a new paradigm of thinking about health, but not just in silos as it has often been the case, but through another comprehensive perspective that really takes into account what matters to people, which is their function. And there are a lot of societal gain from thinking about human functioning. economic implication. I mean, we have our paper in the World Economic Forum say to boost economy, because of course an investment in functioning translate in some economical aspect, but also improve societal welfare through better health system and aligning with the goals of the United Nations Sustainable Development Goal, which is very essential because now it's clear that we need to invest in a society when people can perform. Of course, we have a lot of challenges, and this is why we are now here, because it's not so automatic. We may have heard about functioning, we may have worked already on functioning, but there are some major challenges. First of all, addressing methodologically and implementation hurdle, but also to be able to develop comprehensive data collection and standardization, data standardization, because when we speak about functioning, we are not speaking about one specific characteristic of the person, but we need to have a comprehensive focus on the person because we need to capture the essence of functioning, which is the person in interaction with the society. And this, of course, implies on the level of services, interprofessionality and interprofessional collaboration, because of course, functioning is such a complex, is a unique but complex setting, which requires a lot of interaction in order to be able to account and to fully account for it in society. But of course, there are a lot of educational opportunities. This is why we say functioning is also something that can revolutionize education. Thinking of functioning can become the central core in earth sciences, but can also train a generation of professional, healthcare professional, because we always say person-centered care, person-centered healthcare. But what does it mean really? And functioning has very much in understanding what it means to think about the person in the complexity, and not just in light of the health condition. Of course, health conditions are extremely important to analyze. We need to identify, we need to cure, we need to treat, but functioning is more, because it's what a person can do despite or with the health condition. And in this sense, we really call for the need to bridge between the knowledge that we have about functioning and the implication that this concept can have for society. And of course, I'm a professor of health communication, but this goes back to a lot of communication needs. First of all, we need to spread knowledge about this potential of functioning. This is why the paper, and this is why I'm so happy that today we have all this public from all over the world, because it means that the functioning as a concept rings the bell of something where society needs to invest. And we need to do a lot of advocacy, which means we need to make clear, raise awareness about all of this. This is a first step to then actually implement something to change the system. And we need to enhance public understanding of functioning and to really promote interdisciplinary dialogue. None of us can implement functioning alone. We need platforms like the one that we are having now, and we need to work together exactly to understand how do we coordinate an interdisciplinary response to take into account the concept of functioning. The road, there are many roads, the strategic planning for integrating functioning in health policies, but of course, we are also scientists, so we think that functioning has a main potential to exploit, to develop and exploit human functioning sciences, which is very different from what exists now, because human functioning sciences is really purely a comprehensive perspective, which takes the person at the core of its investigation, but the person not in silos, but the person in its complexity. So, just to conclude, at the authors, we could say that in the dawn of the human functioning revolution, we really stand at the crossroad of health and well-being, where each step forward is a stride toward a future where every individual thrives and not just survive. Seneca says, the Greek philosophers say, is not how many years we live, but is how. And this, Seneca, of course, did not know, but point to functioning. And this revolution isn't just about changing how we see health. It is about remanaging how we live, work, and care for each other in a world where functioning and well-being are the heartbeat of society. This is why we've written this paper, and this is why we welcome very much all this audience with us today. Thank you very much.
Wonderful. Super. Thank you very much, Sara Rubinelli, for that that vision of that the article in Frontiers in Science puts forward. We're going to dig into many of the detail aspects subsequently in a panel discussion with not just the authors, but also reviewers and other experts as well. Before we get to that, however, I'm very, very pleased to welcome Dr. Frederico Guanais. He's Deputy Head of Health at the OECD. He's an international expert in strengthening health systems, primary healthcare, and global health. He serves as the Principal Health Scientist at the Inter-American Development Bank and Chief of Staff to the Minister of Social Development and the Fight Against Hunger in Brazil. In his current role at OECD, he supervises technical work on people-centered healthcare outcomes. It's a great pleasure to have you here, Frederico. Thanks for joining us. And we're looking forward to hearing about the importance of human functioning from a societal perspective. Over to you, Frederico.
Thank you so much, Lee. It's a great pleasure to be here. I'm so happy to see so many people from all around the world. I was looking at the chat. So it's really exciting. Quite an honor to be here. And I think I was reflecting on the presentation that Sara made, and I think there are so many interesting points that I'd like to elaborate further. I could talk a lot about, we're OECD, an economic organization, and we could talk a lot about the economic case for functioning, right? So in terms of, if we have better quality of life, better functional status, then you would be able to reduce foregone wages, long-term care costs, medical costs, and so on. We could also think about the broader macroeconomic terms in terms of the population age structure can be a determinant of economic growth as populations age, so there'll be less people in the labor force. And then that could actually reduce economic growth, and health could become a mediating factor. As people age healthily, though, you would delay the departure of people from the labor force. So this could also be a contributing factor. But I'm not going to talk exactly about that, right? I think the more important thing that I would like to discuss with you today is actually, if health can have such an important impact, how can we actually make sure that we have the right measurements, the right tools, and the right policies, right? To make sure that health systems are more people-centered and the health systems are actually delivering to the people not only additional years of life, but additional years of life with quality. And I think it's Sara already mentioned to you, so there's no need for me to spend too much time on that, on this road to measuring health outcomes that matter to people, this is something that takes decades, even centuries of development in public health. We have gone from measuring the performance of health systems based on number of deaths, so these are measurements such as mortality and life expectancy, and on into diseases, and we're looking at the prevalence and incidence of diseases, and then into disability, right? How health systems deals with disabilities, and we have the DALYs and the QALYs, SF36, and you name it. So we have many there. But actually, we want to go one step further into well-being, right? So how health systems are contributing to the things that matter to patients, to the carers, to the families, and to the population, right? So those are things like well-being, function, quality of life, right? And what happens is that well, we have a lot of discussions about the measurements, but we don't have the data, right? And here at the OECD, this is a question that takes a lot of my time. I mean, actually, it's my mission to make sure that we have these data sources. And that's why at the OECD, we're engaging in the Paris survey. I'm going to talk a little bit more about that later. But reflecting on this historical perspective, I mean, living long is of course a very important goal. We all want to live long lives, and the OECD average has recently has broken through the 80s, right? So on average we have 2/3 of OECD countries actually have life expectancies above 80 years of life. We have some countries that are laggards, but there's been important progress over the last decades, COVID notwithstanding. Um, this is more the case for women than for men that live, about 4 to 5 additional years on average. So, and that's a key metric of the performance of health systems, right? The life expectancy and having long lives. But living long and functioning well is just as important. And as we see the life expectancy at age 55 in OECD countries, women can expect on average to live 21 years of additional life, and men 17 years of additional life. However, if we actually break this down by the years in which are spent with an activity limitation and healthy life years, we see that for women, women live longer than men, but they live more than half of this additional life expectancy with an activity limitation, right? 52% compared to 45% with men. So, of course, the goal should be actually to increase the height of this bar, but actually to increase the proportion of the blue size, the dark blue part of this bar as well, to ensure that as much as possible that these additional life years are spent in good health, in good well-being, in good function. So, of course, as we see this graph, I cannot help but talking about the gender gap that exists. And if we, compare the way women and men age, we see older women are more likely to have non-lethal conditions such as arthritis and depression symptoms. These are things that probably will not kill you. Well, it will in some cases, but most likely will not kill you, but will reduce your quality of life, will reduce your functional status, will reduce your mobility, will cause pain, right? While for men, on the contrary, men are more likely to have lethal conditions such as heart disease, stroke, and diabetes. I'm not going to go into too much detail into the reasons for that, but something that we need to recognize, and then the way that we organize the health system responds to that. And this is very important because ultimately, my argument goes that the health systems should change these metrics into how they can actually contribute to improving the quality of life before and after interventions and throughout the life course. So, and for that, we need new metrics. And here's an example, right? So these are, very technical terms, EQ5D scores, scores that measure health-related quality of life. But the interesting things is that we're working with several countries at the OECD to ensure that these scores are collected before and after elective surgery, for example. And here I have an example of the hip replacement surgery and the knee replacement surgery. So we see that on average, the hip replacement surgery increases more your quality of life score than the knee replacement surgery. These are just examples, right? And examples that I'm giving about the importance of the expectations that people should have in terms of how much is my quality of life expected to improve, but also that the ultimate goal of the interventions is to improve the quality of life, right? Especially for in the case of elective surgery. So we should not lose track of that. And this is something that's very important that should not be taken for granted because very often the patient walks out of a hospital following an intervention and nobody really bothers to measure what happened. Well, the patient was fine, survived the operation, there were no complications, but what happened to the patient 1 month afterwards? 6 months afterwards, 1 year afterwards, right? Did the quality of life actually improve or not? So this is the point precisely of the things we see a good movement of measurement within the hospital sector, but a lot less with primary care. And this is precisely why at the OECD we are conducting this year. I'm very happy that we're almost finishing with the first round in 20 countries, collecting data from 2,000 providers of primary care, 100,000 patients, in actually asking the patients about the outcomes and experiences of care that matter the most for them, right? So in here, we're talking about general health, but also physical health, mental health, social functioning, quality of life, pain, mobility. So all of the things related to functioning that we're talking about today. And we're also talking about the experiences of primary care. You probably know PISA. PISA is a big OECD survey that just came out today that measures the performance of education systems worldwide. Likewise, we want Paris to measure the performance of health systems based on how much they can actually contribute to patients' well-being and quality of life. So one important thing, I mean, I'm not going to, this is a complicated graph, and I'm not going to go into detail with that, but this is the conceptual structure of the Paris survey that we're conducting in all these countries, because we do not only want to measure the functional status across OECD countries, we want to measure what it takes to get there, right? What are the elements of the health system? What are the individual factors? What are the behavioral factors? All of this together and how this contributes to better experiences and outcomes of care. So we want to be able to pinpoint the characteristics of health systems to help countries tailor and adjust policies to actually realize this functioning goal through better intervention of healthcare. This is almost my last slide, and ultimately, health spending should maximize health and well-being. And these are two scatter plots that I really like. Remember that I talked about life expectancy at 65. So, we are economists, so I plotted the female life expectancy at age 65 and the health expenditure across OECD countries. So on the left, you see very nice, clear correlation there. The more you spend, the more you have in terms of you gain in terms of life expectancy. But it's a very, it's a very tight. So it seems that health expenditure is a good predictor of life expectancy at age 65, which is more amenable to healthcare. But if we plot that on the right, and here I'm plotting the health expenditure versus the proportion of years lived in healthy life, in good functioning status. And then you see that, well, there's also a very nice correlation, but there's much more dispersion, right? So my point is that we can do better in actually learning from the best experiences and ensuring that the health expenditure not only adds years of life, but health expenditure actually add years of healthy life. To conclude, my point is that the health system stands at the forefront of this human functioning revolution that we're talking today. So we think that to truly optimize the impact of this revolution, we must embrace innovative metrics, tools, and policies, right? Because ultimately, the goal is not merely to extend the lifespans, but to enrich the quality of every life. And for that, a broader societal response is very important and should be conducted and embraced by all of us. Thank you very much.
Thank you, Frederico, for an excellent presentation. Raises many, many questions, which I'm sure we're going to get to in the next session, or some of them at least. Thank you to our audience around the world for your questions, which are coming through. We are collating those, and we'll bring as many of those as we can to the session at the very end. But for the moment, we're going to explore some of the issues raised by Frederico, also by Sara Rubinelli earlier, in a panel discussion. This is going to be moderated by Gerold Stucki, who we met earlier at the start of the meeting, together with Jerome Bickenbach. Jerome is co-director at the Center of Rehabilitation in Global Health Systems at the University of Lucerne, and co-leader of the Disability Policy and Implementation Research Unit at Swiss Paraplegic Research. As a consultant for WHO, Jerome developed the ICF, the International Classification of Functioning Disability in Health. Joining on the panel today, as well as Professor Sara Rubinelli, who we met before, and Frederico, we also have Professor Walter Frontera from the Department of Physical Medicine and Rehabilitation at the University of Puerto Rico. Previously, Walter was Professor and Chair of Physical Medicine and Rehabilitation at Harvard Medical School and Vanderbilt University in the USA. His pioneering work as a clinician, educator, and researcher in the field of physical medicine and rehabilitation led him being elected to the Institute of Medicine of the National Academies and to receiving many awards. Also with us today is Professor Hannah Cooper, who is Director of the International Centre for Evidence in Disability at London's School of Hygiene and Tropical Medicine. An epidemiologist, Hannah's main research interest is disability in lower and middle income countries, with a particular focus on improving the evidence base to improve disability inclusive healthcare and development. She co-founded the Missing Billion Initiative, working with governments, donors, and health systems to improve global access to healthcare for people with disabilities. Today also with us is Professor Birgit Prodinger, Professor of Inclusive Healthcare at the University of Augsburg in Germany. Birgit's background is occupational therapy, and her research focuses on describing and understanding the lived experience of people with disability and how health systems respond to their needs. She's contributed considerably to the establishment of methods for the standardized reporting and functioning data via the ICF. And finally, with us today is Alexander Pozorak, an economist who has provided policy and strategic advice and led projects in more than 20 countries around the world on applying functioning to disability assessments. Alexander was the World Bank's lead economist and program leader for human development in the South Caucasus, the Philippines, and Southern Africa. And she was the World Bank advisor for disability and development. So thank you all of you for being here today. It's a pleasure to welcome you all. And over to you, Gerold and Jerome, to moderate this next session.
Thank you, Lee. I'm taking the first round at this, and I first have to say that the development of the ICF was a joint effort. I don't take 100% credit for it or blame for it, depending on how you view it. I want to start off by putting Federico and actually Sasha, my colleague from the World Bank, in the forefront here, because the societal impact of the functioning revolution, as we're calling it, is really going to be at the heart of it. I mean, there are infinitely number of interesting technical issues in health sciences, which Gerold Stucki will follow up. But what I want to know is, the impulse of the Sustainable Development Goal number 3 is to make the link, the bridge between investment in health and the outcomes of quality of life and well-being. And you have put this, Frederico, in the context of the kind of work and measurement work you're talking about, but you ducked the issue that you started off with, and that is the important one. How do we persuade governments and to invest more in health? And is it possible that if, although this isn't distributed equally around the world, we are sort of maxing out on life expectancy? There's a natural limit to life expectancy, and we want the whole world to join with the developed world in maxing out life expectancy. But if we emphasize the fact that there's still room for improvement in functioning, people's lives can be optimized even though there's an inevitable decline in health as we age, we can still optimize health. Isn't that a great argument for making the investment case in health? So if I could hear from both Frederico and Sasha on this.
Thank you very much, Jerome. I think, this is, of course, is a very important point. And I'm an economist, so we try to use the economic arguments for that, right? And I think there's the ethical and moral aspects of this dimension that should not be neglected. However, I always get, well, we need to move beyond, advocating, well, because this is important and right, and actually convincing the governments to show, okay, We all agree that this is important, right? But what are the tools and the paths to get there? And I think that that's the important part of the discussion, right? So not only in addition to try to convince, well, let's invest more money in that, but to show which are the pathways that you can invest that will lead to the best return on investment. And the best return on investment, measured here not only in the additional years of life, but actually to additional years of quality, a life with quality. I don't want to oversell the aspect that is only the healthcare system that matters. I've been looking at things in the chat, and I fully agree with that. I think one interesting thing about looking at life expectancy at birth and life expectancy at age 65 is, well, of course, life expectancy at birth is much more sensitive to many other aspects that the developing world is still lacking. Right? So infant mortality rate, for example, is very sensitive to things like access to clean water, right? Maternal education, so many of things like that. So the life expectancy at age 65 is much more sensitive to the healthcare intervention. But still, I think if we maximize the metric of let's just pursue as many years as we can, then we might be led to pursue the kind of let's build more hospitals, let's do aggressive interventions, rather than work with primary care, rather than work with prevention, reorient the system in a way that focuses on the goals of the people, right? And this is what we refer to when we talk about people-centered health systems.
Sashka.
Thank you, Jerome. Thank you, colleagues. This is a really fascinating event and absolutely fascinating topic. This is the future of health, if you ask me. And here I am, I think, in this panel, the only practitioner, somebody who has worked with governments across the world to implement a functioning approach to measuring disability. So to answer your question, Jerome, investing in functioning, it's not the same as investing in health, because functioning depends not only on health interventions, depends on many other aspects, depends on how accommodating the environment in which people experiencing a health condition or impairment live their everyday lives. That includes urban planning policies, includes accessible environment, includes attitudes of people, so adequate social protection, care, etc., etc. And at some point, I think in individual cases, one reaches a point at which health cannot do more. Actually, what one can do more is on the other side of intervention. That is why it is extremely important to look at functioning health, not as an issue of health system only, or health care and health services only, but also on the other side, which may actually be more important as population ages than health system per se. So in that sense, improving functioning health or enabling people to function is optimally or optimized functioning is an excellent investment because of the number of people who may continue to work. That's one aspect. It's actually the number of employees in the economy. I'm an economist, I'm not a doctor, but also investment in productivity. So it's a very smart policy because it improves the way how people experience their health condition and impairment, improves their well-being, but at the same time, it improves and contributes to the economy. So I think we would need to think about functioning more in terms of, at least from my point of view, and from the point of view of persuading governments to move in the direction of the functioning health, is to look as functioning as interaction between a people with a health condition and his or her environment, and of course, personal factors or performance, as the ICF says. Thank you.
Thank you, Alexandra. You mentioned something extremely important. Recently, Alar Kosiesa, who is leading the rehabilitation disability team at WHO, she gave a talk at our Center of Rehab and Global Health Systems, and she has said, we need conceptual clarity. And when I listen here, it seems that we need the functioning revolution first before anything else to get conceptual clarity. And that brings me to the question that I want to bring to Birgit, Birgit Brudding, that has worked with the WHO in the HUFIC network. How can we overcome the confusion? Health, functioning, quality of life. That's the first kind of confusion. And then I would like to also bring in and ask Hannah Cooper and Birgit again, how do we need to disentangle the conceptual reference system of functioning versus how we measure it? So this is kind of what I would like to ask Birgit, and Hannah already nodding. So you have written about that. So Birgit, could you provide us with some conceptual clarity here?
Yes, thank you. Thank you also for being part of such an interesting discussion and panel. As I was listening to the previous talkers, speakers, I find it quite interesting because I think the ICF or human functioning as such provides the conceptual basis for all that have been said. It includes in the activity and participation chapter employment, community and social participation. It includes or addresses in the environmental factors, attitudes, social services, housing services, and so on. So I think we do have with the ICF as a conceptual basis and as a classification, a frame of reference to go ahead. However, has not been developed, or it is not an assessment tool. It does not, it leaves a lot of questions open, as you already said, Gerold. And it gives us room to either address biological health, lived health, or appraised health. And I think this clarity needs to be made before one goes ahead to measure things. So what we try to do is that the first step is to actually clarify or define what somebody wants to measure, and then from what perspective one wants to go ahead. Either it's biological health, lived health, or appraised health. So as Sarah said, if we want to go about our dreams, and the dreams might be or ought to be different by different persons, they will appraise it differently, whether they have achieved the dream or not. That would be appraised health. How people perform later in life, that might also be very different than than the biological health, the intrinsic capacity to health. So the perspective also is, it's not only what to measure, but also how to measure from which perspective. And then the next question is, with which tools do we go ahead to actually measure it? Is there a need to develop new tools, or are there already different tools out there that we can use? And if there are tools out there, there is a lot of advantage to use those, because we maintain historical comparability over time, and we can go back and compare with previous data. The important thing, regardless whether we use existing instruments or develop new tools, is that we think about how can we report those. Because if we are not able to report in a standardized manner, then we lose comparability again. So I think it is very important to go through these steps to, before one starts to measure, and to be clear what the ICF or human functioning can provide. And if we are able to actually exploit the full potential of human functioning and address all the aspects included in the ICF, then we will gain much more transparency, and we'll be able to understand how these different aspects also interact.
Thank you very much. So I think that's very interesting, and I'm now looking forward to Hannah Cooper's view on this. I mean, conceptual clarity, measurement ultimately. What you have written about that in your paper.
So thank you very much. And I really enjoyed what Birgit was just talking about. And she explained very well how it's a very broad concept, functioning, and it's also been, even on this call, interpreted in quite different ways. So the classical example is that it's an umbrella term, and it covers body function and structures and activities and participation, as well as the context. But when we've talked on this call today, people have talked about quality of life, living life with quality, well-being, what people can do, their lived health. and used in lots of different ways. And I do agree with this idea about conceptual clarity and many of the things that Birgit has said, but I would almost add another dimension, which is why we are measuring. So I think if you're in the clinic and you're a clinician, which I am not, you have a lot of time and a lot of tools to look at the person in front of you, what they can or cannot do, what they want to do, and their context, and work out how to bridge that gap. Now, if you're doing a study which is really focused on functioning, and we're working on this at the London School of Hygiene, led by Dorothy Boggs, who's on the call, you can invest a lot of resources in trying to work out functioning, and you can employ a combination of impairment assessments as well as questionnaires and so on, but it takes time. And so I think my question is more that the gap seems to be about if you want something quick for a survey, that is obviously very complex to measure functioning, and it also then brings in this aspect that it would be self-report. And the question with self-report is people can overestimate their difficulties or underestimate their difficulties, or really not know what their difficulties are, or what their needs are. So that is one whole aspect. But then also you're more constrained on time, so it's more difficult to look at this entire umbrella of different components and functioning. And I think for that aspect, if we have that purpose in mind of having to measure functioning, we may need to be more specific or niche about what we mean and what we need to measure and what we can measure in a comparable way. So I sometimes wonder about these things like happiness, these international happiness surveys, that they can be interpreted very differently in different parts of the world. And I've had that same experience with quality of life measures. So we have to have something that gets at the heart of functioning, or the ability of people to do the things they want to do in some way that's comparable. And I'd say maybe for me, the heart of it, if I'm being quite simplistic, is about activities. And it's about whether people can do a core set of activities that you would hope everybody is able to do, and that they can describe how they do it in their own context. And that will reflect both their impairment and body structure, as well as perhaps imply what their participation may be, or what they may be capable of within their context. So I think one of the things that I've missed a little bit in the conversation here is why we want to measure. And I think what we're really centering here is what we want to measure in large-scale surveys, where, as you're saying, and as you've argued in your article, people have now accepted functioning is really important. It has to be measured everywhere, not just in functioning-specific projects, but then how do we do it?
Yeah, thank you so much. I mean, that is a wonderful also then segue to the next area of implementation, because as Birgit said, it's the purpose, and you say you have to really now outlined many different, what WHO would call use cases, if one look at it from a governmental perspective. So we will talk about human functioning science, the science aspect later, maybe that is more covered by Jerome, but the one thing that really is worrying is the following. In terms of implementation, again, Ala Kosiesa, that was working on this for a long time, she said, I'm really not impressed by the fact that functioning has not been implemented in health statistics. And there was one comment that said, I think it was Dr. Kambu from Cameroon that said, can you give us a good example? And we have some people here that are working with the World Bank. Alexandra, Walter is very much involved in rehab that uses functioning as an indicator, and maybe then Sara on advocacy. So we realize implementation depends on the purpose. It's like the ICD, you use it for very different purposes. So could you enlighten us, Alexandra, and then Walter, from your perspectives, your experience, how, and then Sara on advocacy, how could ultimately this indicator of functioning be implemented so that it can serve, as Hannah says, different purposes, and that it's not just something that remains conceptual but becomes more real in health statistics? Alexandra.
Thank you. Thank you very much for this extremely important question. And in my policy outlook reflection on the article, a beautiful article, very important article that you have written, I have in a way expressed a bit of my frustration how difficult it is to persuade governments, because it is about the governments. They will have to collect the data, they will have to report and measure functioning. How difficult it is even to explain to them what functioning is. Most shocking to me, and I have worked, I think I have spoken with officials maybe in 30 countries or maybe even more on this measuring disability, but disability is functioning. It is activities and participation in the ICF. They simply have no idea. And the worst are the doctors, with huge, actually, apology to rehab PMR staff, because everything is clear to them, but they're not important. They are not in, first of all, there are not that many PMR professionals in any country I have been, including highly developed countries, and they are not in the structures that are deciding on disability measurement or disability assessment or health statistics. And because at the end of the day, people talk about functioning. So you go and you discuss and it's functioning. But then when it comes to measurement, it's absolutely unbelievable how quickly they go back to medical approach to disability. And you tell them, in your constitution, in your legal system, you accepted the definition of disability, which actually is the one that's spelled in the convention and the ICF, and yet you go back to medical approach. They measure impairment in percentages or health status. They use baremic tables, sometimes very old fashioned baremic tables, etc., etc. So the question to me is, and I will stop here, is how we make sure that medical professionals, doctors, understand functioning, because they have to understand what functioning health is. They don't right now. They talk about functioning as a medical phenomenon, and it's not. And it's very hard to explain and to persuade them. So we have, going to the measurement issue, we have implemented in 7 countries large-scale pilots on the instrument for measuring disability or measuring functioning that was developed by the World Health Organization, which is called World Health Organization Disability Assessment Schedule. It's not perfect. Nothing ever is perfect in measuring a concept such as functioning, but we have, I think, about 22,000 interviews in those 7 countries. The instrument has performed psychometrically extremely well. And if you use the Rush scale and transform the raw PUDAS score into 0 to 100 scale, then you get a point for each single individual on 0 to 100. It could be 50, it could be 20, it could be 60, which reflects the functioning or activities and participation of that particular person. So it's not a perfect instrument, but it is a good instrument. And that instrument, if employed in a relatively short period of time, could actually give us lots of evidence about functioning health, an indicator which could be then used to be reported as an indicator of functioning health. I don't think we should be waiting for a perfect instrument, because such thing does not exist. Over.
Walter, could you take the next step, answer this?
Well, thank you very much, Jerome, and for the opportunity to be part of this great discussion about something that is clearly very important. I think we have a lot of challenges that have been already mentioned. In my comment about the paper that was published by you and the others and your co-authors, I try to focus on the opportunity that we may have in the context of the aging society. Not because this is limited to the aging society, but because I think it's an opportunity. It's something that governments cannot ignore, and that we should take advantage of it as a way of testing some of the ideas that we're discussing today. It's a case study to some degree. But I think that we see a couple of challenges when we do that. One is that there is an effort by the US National Academy of Medicine in the area of healthy longevity. This is not a national effort, this is an international effort. They have 50 countries that participate in this. And they have developed a roadmap for healthy longevity and a global competition for grants that would explore innovative approaches to healthy longevity. But even though the term function is used in the definition of this, it is not included in operational terms. And if you look at the projects that are being developed, they really don't focus on function or functioning. But my point is that this is an opportunity to influence something that is truly international, that does not depend on the government to advance the ideas that we're developing or discussing today. Number two, one of the challenges in this same context that has been mentioned already, but I think it's important to look at this, is there's a group at the Mayo Clinic in the US that looked at this, the potential use of artificial intelligence to gather data on functioning using electronic health records. And the results were not surprising, and they were not positive in the sense that the source of data that we have for morbidity and mortality really does not work for functioning, because the quality, the diversity of data, the way the data were recorded, observations and so on, really there was no way to mix them, to use them together, to make sense of them, and to actually make sure that the health system was a learning health system from a functioning point of view. And so there we have a very concrete challenge. In some countries, this data collection does not depend on the government. It depends on the health systems that may function together, but to some degree independent from the government. So how do we influence those people that have used morbidity and mortality for years and years and years to develop or conceptualize quality of life and so on? How do we convince them that they have to include in their systems something about functioning? Clearly, I agree with other speakers that we need consensus on the definition of what we're talking about and a way of measuring it. What is the tool that we're going to use? And one idea perhaps is, this may go back a long time, but how did morbidity and mortality become such an important indicators in health systems? Why did that happen? And who decided that those were the important health indicators? And is there a story there that we can learn from as we try to do the same thing with functioning, putting functioning at the same or maybe higher level of relevance than morbidity and mortality? So, but back to your question, I'm looking at this. I reacted to the paper in the context of the aging society, healthy longevity, because I think it's an opportunity. And clearly because aging is much more than a health service delivery question. It has to do with other elements of society and so on that should be part of this. So those are some of the comments that I wanted to make to your question.
Thanks a lot. I'm mindful of time, and I don't know if Lee wants to switch over to the audience questions now, or because we still have, be nice to hear from Sarah with respect to, I mean, she can fix all of this stuff with a wipe of her hand, so it'd be nice to hear from her. But
I think so. No, go ahead. Go ahead.
Sarah, how do we convince governments?
We enter now in the major issue of advocacy that we know is everybody speaks of advocacy now, but I have to say, I always say this: if you look online, you see thousands of different understanding of what is advocacy. So I always say we need to start from what we have. We have we know what is functioning. This now we know. We know what is functioning and we know the value. Let's put it in Aristotelian category, potential value of functioning. That means we need to now start to work together with people, because this is always the major problem. What you were saying before, Alexandra, is really an issue of getting together. And we cannot think now we change this worldwide, because it doesn't work. It's like the campaign, a health campaign. You don't target the world. You have to start in the country, because each country has different things. For example, I was looking at the question. Some people ask, but what about low-income countries? What about when we do not have resources? Or what about situation like in Switzerland, where we do have some resources, but as we know, functioning is still not the gold standard of anything. So I think we need to really think, and we need to become ambassador of this and work together with the key stakeholders. I think for me, the major issue, what we have to do, we have to identify the key people and not thinking that this is our individual endeavor, but is a country or even a region endeavor. But we need to start from here in a structured way. And this is why meetings like this today are essential, because we set up the stage to then base advocacy within the individual place, where each of these, now I can see 250 people are in the public, they can all do something in their own thing. But of course, you need to start from what we know and not putting again in discussion a lot of things, because otherwise it's a never-ending discussion. Because then some people say, but functioning is not clear, functioning is, no, we know. This is the perspective. Why, Walter, mortality and morbidity? Because these are I think these are very easy to understand for people. And everybody would think that dying is an important factor. You know, why? Because nobody likes. So there is an immediate and natural agreement on that. With functioning, we'll all live functioning, because if we have a health condition, we cannot do things and we get upset because our functioning prevents us from doing what we want to do. But we need to now say, this is important. It's a natural thing that we experience, and this is important. And structure from here. So building human functioning sciences would be already a major initiative. Having a dedicated section for journal of research and having a structured approach for advocacy in the field, those are the things that, in my view, would be very essential.
Okay, I think we'll move to the audience Q&A. First of all, though, thank you to everybody in the panel for your contributions, and just for our audience to know as well, the Frontiers in Science lead article is in a hub of information. So there are viewpoint articles both by Hannah and by Walter, who referred to these just before. There's an editorial by Francesco Colombo, head of health at OECD. And also Alexandra, who is with us here, provides a policy outlook piece as well. All this material is on the hub page, and please do go and read it there. For the time being, just to move to some questions, and we'll try and get through as many as we can. First of all, speaking to Sarah, following on from your point there, and I put this out there to perhaps Alexandra first, but for you all. Several questions have pointed to the importance of not only the application of implementation of functioning in health systems and policies in low middle income countries, but in relation to climate change and the impact that that's having on people's lived environments and activities. And this, as we know, increasing recognition about the impact of climate change on human health. Is this a new trajectory that needs to be explored in human functioning, a new dimension, I should say? And have you got any reflections on, not wanting to add further complexity to an already complex problem, but what are your reflections on how do we How is climate change and its impact going to be integrated into this thinking in the coming years? Who wants to go for that one first? Alexandra, perhaps. I know, Alexandra, we know you know your work in around the world. Perhaps if you want to kick us off there.
Yeah, that's the beauty of the concept of the functioning health is that it's applicable to humans. Health functioning or functioning health is actually human condition. So irrespective of whether a country is poor or high income country, is applicable and can be implemented. And in my experience, it's actually much easier for low-income countries to accept or to adopt concepts or measurement or implement instruments such as HUDAs than highly developed countries that already have a structured system and systems that are well established or calcified in many ways with lots of vested interests, are very difficult to move. So it's much easier for low-income countries to do that. Again, the climate change issues are just lend itself or functioning lends itself to that environment. And the change in the environment makes actually your experience of your health condition much more difficult if it's not addressed in a satisfactory manner. So it is an important aspect that is changing environment in which we function, which we conduct or carry out our everyday activities, health or no health condition, impairment or no impairment. And therefore, I think we also need to add climate change to when we discuss functioning health. That's my take on it. Thank you.
Okay, next question. Several questions come through on social welfare and social workers. The lead article speaks to the need to integrate health systems and social welfare systems. But specifically questions come in about social workers. What role for social workers in the implementation and improving functioning and social welfare functions more generally? Gerold, I can see you nodding.
Yeah, so if it's not, the question is always when you bring the different disciplines that you should be mutually exclusive and cumulative exhaustive. So definitely all those different professions and professional disciplines must be there. So if it's not there, then it's a mistake and should be there. Absolutely. And I think that is also speaks also, by the way, for the idea to create a distinct scientific field, because that is an issue. How can you bring those disciplines together to study the lived experience in relation to all those different environmental issues, where you live and so on? And I like that comment. I also have seen it, and I think that is really sometimes a little bit a missed opportunity so far. And I would like to add one more point. You could actually think about functioning as a concept of study the lived experience, and not just as the study the lived experience of health. So in that sense, it's absolutely clear that functioning as a conceptual approach should allow to study all those interactions in and bring in the different perspectives and contribution from social work, sociology.
Yeah, Walter and Birgit and Hannah, could I ask you to also, as you will, to comment on how in practice are these disciplines collaborating? How could that better be done in the future, so that even if there's a field of human functioning sciences, even if it's sort of how does that be joined together in this? How is that research best coordinated? Obviously, I guess it depends on the specific field and which professionals and academics would necessarily be involved. but how would you see a multi or actually an interdisciplinarity? I think we're talking about interdisciplinarity here, right? That is groups working together and learning their models and developing something, a synthesis that's more than a multidisciplinary working in isolation on a common problem. Is it interdisciplinary, and how can it best be fostered? Hannah, please, if you will.
So it's a really interesting question, because from an epidemiological perspective, different groups are collecting data in different ways. And so if I think about the UK, which is an area that I know best, obviously, the UK NHS datasets are an incredibly rich resource that can be analysed. And there's an amazing amount of data about health and medication and status, and it can also be linked to death outcomes. So that's really, really rich. But the problem for me as an epidemiologist interested in disability is there isn't data on disability. There isn't good data on disability, however we want to measure. And so we've been grappling a little bit with this issue, and it's the same issue in different kinds of countries. And so the one is to link to other groups that are measuring disability for different purposes. So it could be these kinds of functional assessments that are done to consider whether people can work, for instance, or whether people should get a disability benefit or a blue badge for cars. And so those are different kinds of sectors that are collecting data on what people can or can't do for different ways. And you could link them to really rich medical data to start trying to learn more. The other thing which we haven't really talked about, and I don't know much about, is the possibilities for AI. So I know, for instance, again, with these really rich data sets, is that you can use machine learning that to try and look at what level of functioning you think there can be for people with different kinds of conditions. And that, again, needs to be rooted in a kind of a starter sample where you do know their functional level, which again can go back to this interdisciplinary, getting data from different sources that's collected in different way with different purposes. So I do think we're going to have to think a lot more about big data. I think about how to use data that is already collected for different purposes that we can then reuse for our purposes, and the opportunities of AI within that.
Actually, if I may, perhaps Walter, we could bounce this to you as well. So we had another question actually from Jerome Bickenbach, who's Frontier's chief editor in systems biology, on the point that the holism that we're talking about would seem to beg a systems computational modeling approach, integrating biological, physiological, clinical, economic factors, social factors, I guess. Walter, you spoke of the fact that there's challenges in the interoperability or the quality of data sets and within observational data resources, right? Not done for that purpose necessarily. So could you comment on that? What is the likelihood of advances that would use machine learning and computational approaches to integrate these different data sets? It must be hugely challenging.
Yeah. Well, thank you for the opportunity. I agree with Hannah's comments. I'm not an expert in computational biology, but one of the things that I think would make sense to me is that we gotta get people to think about the question first. So people come together because there is a question that needs to be addressed from different angles, but that they work together in addressing that question before they start collecting data. They have a discussion about the question before they start collecting data. So it's, to some degree, you need to restructure the way those kinds of questions are being answered in research. And that may include clinical trials, but it's not limited to clinical trials by any means. So that's number one. And that would be something that we would need to promote now with people who are doing research in this field or who could potentially contribute to this. Right now, the data collection in health systems is simply responding to different questions from different professions. They are not talking to each other. It's not integrated. So I think we would need to address that. The second thing is that thinking about the future, and someone mentioned this challenge of education of health professionals. And I think that would be for the future then. This particular idea, the idea of functioning, has to be introduced into the professional schools now, so we can in the future have a generation of people that can understand the concept much better and can work together to address important questions in related to functioning. So I think we have a strategy. We would need a strategy for short-term effect by working with people who are already maybe collecting data, thinking about questions and so on, and probably a longer-term strategy, which is at the level of the workforce training, education of healthcare professionals and so on. And I'm not thinking physicians only, of course. It has to be everybody that may have an interest from different angles on this particular issue. Thank you.
Yeah, actually, Walter, you preempted what would have been the next question. Actually, there's been a few mentions in the chat from our audience about medical education, but if we were to broaden that to healthcare professional education, I don't know whether anybody else wants to speak to that, maybe Gerold or Jerome. What initiatives, are there initiatives underway to give a kind of a standardized education to healthcare professionals? Because of course the education varies enormously, even within a country, or never mind between countries. What's the right routes or platforms to try and boost the medical healthcare professional education in functioning? Where would it start, or if it's already started, where would it go?
I think Birgit is well placed to answer that. Maybe Birgit, you want to start. Birgit Broding, you have the most experience in that, I guess.
There are certainly some of the health professionals that have it already in the standard curricula, that ICF is part of it. And it brings me to what Sarah said. We need to identify the key stakeholder, and Alexandra made the point of medical doctors not knowing the ICF. If it's not in their medical education, if they are then coming into clinical settings where they are asked to reduce readmission rates and so on, there is no incentive to actually implement functioning. So I think the key stakeholders are very important to ensure that we bring it into the educational curricula in all health professions, but then also have good examples in practice where it is implemented and it does work. And when we talk about implementation, we often see human functioning, in particular in rehabilitation, the concept of human functioning implemented, that there is an interdisciplinary goal setting using the ICF as a frame of reference, but we don't have the data then collected comprehensively according to the ICF. So there's also big differences and heterogeneity of how the ICF is then taking up in practice. And I think there is it is important to clarify again, what is the purpose? Do we want to use the concept, or do we want to collect data? And how do we move forward then?
If I could ask each of you, if this is one way to do it, could you just each of you give an example? Where can we point to successful implementations of health functioning in a health system at, it might be the national level, it might even be a more local level? What would you, if you were to be asked for one example of what you would see as success, good practice, that you would like to bring to an audience globally that we have online right now, what would it be? What's the one thing that you would point people and say, look at that for what we can do, even at a local level or a national level? Hannah, may I ask you to comment on that? Sorry to throw you there, but
that's fine. And I'm going to be, I'm afraid I'm going to blow our own trumpet on this, so please forgive me.
Go for it. Go for it.
So at the London School of Hygiene, we've struggled with this for a long time, and we know how very important functioning is and how it really needs to be measured well to show what the needs are in the population for AT, for rehabilitation, and so on. And work led by Dorothy in our group shows that, you know, these impairment measures are obviously only one aspect of functioning. But on the other hand, if we turn all the way to self-report, there are lots of gaps, and it's not very clear what they are telling us. And so what's taken a very long time is to develop a mobile app that brings together those different aspects so that there's kind of a screening, a pre-screening through self-report to identify people who are likely have difficulties with functioning. And then there's in-depth examination, both using impairment tools as well as self-report and questioning, looking very holistically at functioning. And that the purpose of that tool has really been to do surveys, particularly in low and middle income countries, about what the prevalence is of different kind of functional difficulties to see what the needs are. It's also a tool that could be adapted for certain settings where there isn't a clinician, say in a refugee camp or after a crisis, to see what the needs are. And so I found that quite an inspiring example to watch on, to see what's possible, bringing together the best evidence from different sources, but also harnessing the power of mobile technology and these amazing new tools to do things like hearing impairment assessments and visual impairment assessments using mobile tools.
Great. Birgit, do you have an example to bring to us or a thought on this?
Yes, I link back to the education. We do have some courses that are interdisciplinary, so where different health professionals, including medical doctors, physiotherapists, nurses, occupational therapists, are doing certain modules together. And then human functioning is at the core and provides them with the common frame of reference and the common language.
Great. And Walter, may I ask you, just again, drawing on a vast experience, I know, but can you point to one or two examples of real exceptional practice that you would like to see as duplicated, if you like, scaled up?
Well, in thinking about one that we're testing in a research setting at this point in time, that is a community-based intervention for older adults, combining exercise and mental health as a dual intervention, because these are older adults that have mild to moderate level of impairment, to put it in those terms. So we can get into a technical discussion about that, but and so this idea was tested in a lab first in a very controlled setting. Now it's being tested at the community level. But ultimately, what we want those people to be or to do is to be healthier, happier, and to work. And so, is this something that we can accomplish? Of course, this is an ongoing project. We don't have the results yet and so on, but it is really an attempt to make sure that we can influence several aspects of the lives of these individuals with an intervention that is well known to be effective in a different setting. So this is not an experimental intervention. It's simply a combination of two things that we know work in older adults. And so that's one approach. And if these kinds of interventions work, then we can use them in different communities. Of course, they have to be adapted to the communities and the countries and so on. And by the way, the group that we're studying includes different races and ethnicities. This is in the US, but it's a multi-racial group. And it's actually a multi-center trial in 4 different cities. So I think we're trying to address all of those differences between groups and see whether this can actually work. Now, let me say, this is something that we're trying to do without having to come together and define what functioning is and how to measure it. We're using instruments that are out there that have been validated, like the short physical performance battery for older adults and so on. But we're doing it in spite of the fact that health professionals involved in the study may have different definitions of what we're trying to accomplish.
Right. Well, we look forward to seeing the results and good luck. It's the end of the session almost. I'd just like to zoom out a little bit. We just went in depth there to a local example or institutional examples, just to zoom back out again before we close. And Frederico, may I ask you first of all, and then Jerome and perhaps Gerold, back to the big picture. We started out with the society, we went deep, and now we're going to come back out again. From your viewpoint, how do you see human functioning realizing the value of health over the next decade or so?
Lee, I think, that's what we work for. And making a connection with your previous question, if you ask me, where are the good practices? The answer is, I don't know. But in 1 year time, I'm going to have a much better answer for you on that, because we're just finishing the Paris survey, right? And I think that the really important thing is that we're collecting maybe not the exact precise instruments that are being discussed here, but there will be several instruments that I'm sure that researchers can correlate and crosswalk into the validated scales. I mean, those are validated scales elsewhere. The characteristics of health systems, the characteristics of population, socioeconomic factors, individual factors, and then we are going to be able to actually put this all together. And then we really need and want to engage with the researchers in the field, actually to make sure that we shape the discussion about health policies based on this evidence. So where are we going to be? It's up to us to build this road, right? Based on identifying the best practices, the policies that work at scale. And then, the role of having the vehicles to disseminate this knowledge and to promote this conversation will be key. So I think it's a very exciting time, and I expect this decade will be transformative in terms of this conversation that we're having about today.
Wonderful. So, Jerome, would you like to say a few closing words?
Yeah, I was just thinking that revolution is a big word, and we were very bold in our claims about it. But taking a step back, I always think in roughly very simple terms. I mean, a colleague of mine once said, it's very simply, you can not just add years to life, but add life to years. I mean, what matters to people about their life is, in a sense, their longevity, is in a sense how long they live. But increasingly, most people I don't think this is a big conceptual leap. What matters to you about your health is what you do with your health. At the end of the day, what matters to you is not the technical morbidity of a particular disease situation, unless you're a doctor at the same time. What matters to you is how painful it is walking upstairs, how limited I am in my ability to communicate with people, how limited am I in my aspirations to a particular employment. And that is the realm of functioning. Now, the realm of functioning is the realm of disability. There is no difference between the two. And part of what this discussion and the article was about was to be, and we've said it a couple of times, about clear with our ideas and not to mush things up by having the notion of functioning be identified with, say, quality of life, of which they're entirely different notions. And it's very clear as a step toward measurement and other further clarities and adoption that we have conceptual clarity. And I hope our revolutionary paper was a step toward that.
Super. And Gerold, perhaps just the last word from you.
Sure.
Nothing to add?
I fully agree with Federico and Jerome. 2 concrete points. We need to have functioning information as a third indicator in health statistics, as much as we have data on mortality, morbidity. And I would like to see the growth of a scientific community, whether it's called human functioning sciences or not, that actually takes this seriously and advances the field.
Wonderful. Well, thank you for those closing words. And thank you to all, to Gerold Stucki, to Jerome Bickenbach, to Sara Rubinelli, Frederico Guanais, Walter Frontera, Hannah Cooper, Birgit Prodinger, and Alexander Pozarak for being here today. Most importantly, thank you to all for joining us. I hope you enjoyed the session. Please do visit Frontiers in Science to read the article that we've discussed today and its hub of content. You can follow, as always, on social media with the hashtag Frontiers Forum. Subscribe, please, to our newsletter at the Frontiers in Science website. But for now, thank you very much for being here, and see you next time.